Hi everyone, and apologies for the first few slides for those of you who might have seen me speak this morning. So the partnership is where we begin, but first, very briefly, for the new people in the room, UQ Healthcare is fully owned by the University of Queensland. We are a not-for-profit. It's part of the GP Superclinic funding, and as such is very much a GP model in the first instance, but part of our full brief is that we have an allied health and a full range of services with an education and research focus. Committed to that sort of program development, including student involvement. So that's where we became involved with this project. The project around child wellbeing started with identified need in the West Moreton Hospital and Health Service. About 2 years ago, the West Moreton Hospital and Health Service approached UQ Healthcare and started some preliminary discussions. And it was about when there needing to be early intervention for children who were on the waiting list, around the development of problems which then become linked with mental health conditions as well as chronic disease and poor occupation and social engagement. So there was recognition that there were constraints in the Ipswich area in terms of meeting those needs, and as I said, there was a significant waiting list. So the aims of the project was we're looking at a sustainable delivery model, which was an interagency model. And early on with the steering group and the working party, that was very much a part of what we wanted to do, was to work with education, health, ourselves, Medicare locals and others. I guess part of the other, obviously the aims were to create and enhance clinical training placements and that the service be student assisted in its delivery. We certainly had an IPE emphasis from the beginning, and I'll talk more about that as we go. So just to, this was really, I guess, this was so important for us because this is where it all began in all of the models that we've developed, because it was around having identified need for gaps in services, or in this case waiting lists, and then of course needs in terms of student placement provision. So I mentioned those partners earlier. UQ is our major partner, but of course we've worked with other universities as well in this process. Well, I mentioned these this morning as well, but again, IPE was an absolute core tenet to this. So I guess that was part of our discussions with the universities coming on board, was that did they see their students working in an IPE model, and I guess some work around, well, what would that look like? The service delivery focus was very targeted because we were looking at that waiting list in collaboration with West Moreton HHS. And students were going to be an active participant in addressing that. So those sorts of things were absolutely recognised from the outset. The program itself looked at interdisciplinary triaging and screening, and I'll show you a flowchart of this more simply in a moment. But the student, I guess what we were interested in as a working group is where's the scope of practice for the students within this. So we looked at where can the students have a role which doesn't compromise the care of the child. Now, I guess to give a little bit more background, the waiting list was a little bit like a bottleneck. So these were GP referrals, and that was our interest as well. GP referrals to a paediatrician. So without them being seen by the paediatrician, they were staying on the waiting list at West Moreton, and they didn't have access to an interdisciplinary assessment at that stage. So for us, that was a key part of it, was to look at an interdisciplinary assessment prior to us being able to then make some impact on that waiting list in conjunction. So I'll go across the next couple of slides to pick up on this a bit more. Just on my way there, just to say that in the first instance, the key disciplines involved have been psychology, occupational therapy and speech pathology, with plans to work with social work next year, and of course medicine as well, paediatricians as well. So this, I guess, I showed this morning, so this just shows how that very basic flow worked, but the delivery at this stage has been around addressing those referrals, and then having a case conference with the paediatrician Ian Shellshear from the hospital to discuss. So at this point in time, who of these children still need to see the paediatrician, who can be, of them, who can be seen by one of the other disciplines, and then coming back to a case conference later on in terms of where to from here. The group sessions is something that's a work in progress. So we're talking about having parent education component to this, which would be run by the psychology students in large part, in conjunction with the other with a student from another discipline as well. And the other part of this, which is a work in progress, is having interventions done in a group environment. So whilst the interprofessional assessment is going on, and there's some opportunity for individual collaboration or individual client sessions, at this stage we haven't done any group client sessions. So that's just, so we're looking at the years for prep up to year 7. So I guess the key points in terms of the student assisted program was having matched students with an area of clinical need. Was that clinical supervision model was about having clinicians on board who had expertise in the area. So we've worked with clinical educators, some of whom have experience working in the public sector, some currently work in the private sector, and they've come on board part-time, and the clinic has been running across 2 days a week, a Monday and Tuesday at Ipswich. Part of that was assisting some of them to feel skilled in supervising students from a discipline that wasn't of their own, and we've developed some tools and used other tools that are already out there in regard to that. In terms of the ongoing stakeholder engagement at the working group level, that's been to assist us to continue to reinforce that referral pathway and to understand where we need to review the model. One of the challenges in that part of our picture at this point in time is that we were anticipating that there might be an opportunity for Ian to work with us on an Option A agreement, and that we didn't anticipate that taking as long as it's taking, and we're not quite sure what the outcome of that will be at this stage. So we had envisaged that he would actually come and do a full session a week and then do the case conference, whereas at this stage we've only got to the point where he's able to join us for the case conference. So to date, there's been 155 placement days. That's across those 3 disciplines I mentioned earlier. So the placement days are higher for speech pathology, and that's to do with the length of the placement period. But there have been actually 2 students from each of those disciplines involved. The actual discipline-specific assessments required have been relatively even across that time, even though we've got more scope. I beg your pardon, I should say the speech pathology students, even though in terms of placement days they're there for longer, they're actually there only across 2 days of the week, as are the OT students, whereas the psychology students, we've actually got some more psychology student involvement now across 4 days of the week. So looking back at where we got the clients from, which was critical in terms of being able to sustain a placement model and a placement experience for students, of those parents addressed to be involved in the program, there's been an 89% attendance rate. So the level of parents' willingness to participate in a student-assisted service has been extremely high, and the feedback around their engagement in that process has been very positive. So I suppose our early observations is that students provide valuable IPE, it provides a valuable learning experience for the students, but that the students provide an important role in actually facilitating access to service. So in a talk earlier today, the comment was made that without this assessment service, these children, they were talking about another service, but in our case, without this service, these children would most likely still be on the waiting list and would not have accessed any assessment up until this point in time. And they are, most of them, still, if for those that still do need to see a paediatrician, they are still on the waiting list to see Ian for a full assessment. But what we've learned also is that the clinical governance around this is obviously critical to build community trust in what we're doing, using students as part of that delivery. And that's somewhat compromised if we don't get Ian on board for our full session. So where to from here includes starting to develop stronger relationships with other psychiatrists and paediatricians as well, in terms of how we might continue to grow that model, and certainly to embed the student role in a routine placement schedule to allow those assessments to continue. Thank you very much. I would just like to recognise there were many people involved. These are the names here are those who have been involved in terms of actually delivering the service, but the work across with the universities and West Moreton and the Medicare Local have been, we wouldn't be here without that whole collaboration. Yeah, thank you.
Thank you, Frances.